Perfect. Great. Hi, everyone. Thanks for sticking in till the end. Right, the last didactic section of the day. You should all be impressed with your stamina. My name's Phil Magidson. I'm an emergency medicine physician and geriatrician. I'm used to moving around, but I'll do my best to hold still. An emergency medicine physician and geriatrician from Baltimore, Maryland. Excited to talk about a topic that I am passionate about and that I hope will highlight a particularly vulnerable patient population, really sort of challenge you to take a more active role in protecting these patients and really providing the patient-centered care that they deserve. Now, some might say that I stand between you and happy hour, but I would contend that happy hour begins right now, and you are all about to be recipients of geriatric emergency medicine pearls as intoxicating and euphoric as the stiffest gimlet. So I'm glad you're here, and I'm confident that when you join your compatriots at happy hour and dinner, you already have a little bit of a buzz going. So let's start with a little warm-up. So I'm going to project a couple of pictorial graphics, and I want you can keep it to yourself, you can say it out loud, say whether there's sort of a positive, neutral, or negative connotation associated with that, and I will share sort of my thoughts as well. So first one, heart with some electrocardiographic activity. I don't know, this is probably somewhat neutral, it's not a STEMI, I don't know exactly what it is. Some hands holding a nice heart, that's somewhat warm, and I would say there's a positive connotation with that. Some books, I like learning, I like reading, negative at worst, probably positive. The balanced scales of justice, right? This could go on a business card for an attorney. I would say this is positive. These same hands now hugging a group of people. This looks positive to me, I would say. What about a kyphotic patient with a mobility device? Now the patient's even more kyphotic with a worsening mobility device. I don't think any geriatrician would put that on their business card. And I think you probably recognize these, right? These are sort of the pictorial graphics that go along with some of the activities at SAEM. The last one being the geriatric talks and various activities. This was from AGEM just a couple of weeks ago in Austin. I think those are a little more negative. And that's sort of the segue into what I call the last socially acceptable prejudice. We're going to talk a little bit about ageism, and particularly ageism in emergency medicine. So I think it's actually pretty easy to identify, and so we'll talk about some specific examples and sort of why I think that's the case. Describe health consequences associated with aging. It's not only just mean, but it's associated with real morbidity, real mortality. And then I want to sort of highlight some tools or ways and things you can think about to really sort of implement really at sort of the personal level what you can do to battle ageism, but what we can also do from sort of a health system and hospital system as well. So this is sort of not a heavy lift, but right, we should just define it. So ageism, stereotypes, prejudice, discrimination towards others or oneself based on age. I think you could substitute racism in there, sexism. I think one thing that stands out is not only how we perceive older adults or younger people perceive older adults, but also how they perceive themselves. And we'll talk a little bit more about that. I think that's an important point. So ageism in emergency medicine, I think is real, and I think there are a number of reasons. So we disproportionately see frail, ill, cognitively, mobility impaired older adults, right? We don't see people like Ann Garrett, who just stops by to say, hey, want to let you know I set the national record in the half marathon for the 80 to 84 age group, right? That's not who we see, and I think that's true of other conditions and other patient populations as well. I would argue, my head is not sort of in the education space, but I would argue that geriatrics is not emphasized in medical education and not in emergency medicine. We all do pediatric rotations throughout our emergency medicine training, and I think we should. I don't think there's anything wrong with that. I think a PICU rotation is fine, working in the pediatric emergency department. But I bet if you sort of surveyed all of the participants here, there's a good percentage of people who do not see pediatric patients at all. I also think that obstetrical rotations are important, but I'm going to tell you 95% of the deliveries I've done were during my obstetrical rotation and not sort of post attending life. But I think probably in this room, and people who primarily see older adults tend to see a large percentage of older adults, and I don't know that a lot of people had sort of dedicated geriatric training. I think the EM approach, and not not inappropriately so, just given our sort of limited information, tends to be a little binary, especially for junior physicians and junior learners, right? What is one of the first things that we ask our interns or medical students, right? Is this patient sick or not, right? Is this EKG someone we need to call a cath attending or not? This patient is septic, do they get 30 cc's per kilo or not? We all know who have practiced emergency medicine for any period of time, there's more nuance in that, right? It is not that simple. But particularly when it comes to older adults who are in sort of a different time-space continuum of life, that nuance is quite pronounced, right? And so that binary approach that I think particularly junior physicians have doesn't work well at all for geriatric patients. So I want to frame a couple of cases that I think highlights ageism in the emergency department. So the first one is a 78-year-old gentleman coming in with some lower extremity edema for 2 weeks. Patient's daughter says, you know, Dad left his hearing aids at home, and sort of jumps in to start telling you the history. Perhaps many of us would be happy that she is there, and it's great that he has a care partner. But is there anything ageist about that encounter? And I would contrast that with case 1B, so a 78-year-old gentleman, a Cuban immigrant coming in with worsening lower extremity edema. Patient's wife is at the bedside, says, you know, my husband's English is not very good. His preferred language is Spanish. Let me tell you the history. I think many people here would say, well, now just wait a second. We need to have an approved language interpreter. We need to have someone who can speak Spanish, and that's the right approach, right? In fact, I take a recurrent training every year at Hopkins emphasizing the importance of language services. And it is true, right? That is important. But just as English not being a primary language can complicate communication, so does age-related hearing and vision loss. And I'm not certain that we have a consistent method to address that. Some departments perhaps do, but we really should offer similar accommodations, and I don't know that we do for older adults. 89-year-old female coming in with fatigue, abdominal pain, dyspnea on exertion, no chest pain. Your intern says, I think older adults can present atypically for acute coronary syndrome. Should we get an EKG? And the answer is yes, we should get an EKG. Is there anything ageist with that statement or that approach? And I would contrast that with 2B, 49-year-old gentleman coming in with 1 day of substernal chest pressure and vomiting. Intern says, these sound like typical ACS symptoms. Should we get an EKG? Again, yes, we should get an EKG, but older adults present differently than younger patients. I think there's a little bit of a problem with the word atypical, right? I mean, it's atypical if we're using young white men as typical, but older adults present differently. I think they, in many situations, should have different vital sign parameters. You know, the presentation, symptomatology is different. And I do think that word choice matters and makes a difference. What about this cool cat? This guy looks fun. 81-year-old. He likes skateboarding, he's not particularly good at it, falls off, coming in with right hip pain, subsequently discovered to have a hip fracture. I think some departments are good at managing this, and others would call orthopedics, and orthopedics says, well, he has a couple of medical problems, he should go to the medicine service. Medicine says, well, it's a traumatic injury, you should call trauma. Trauma says it's an isolated orthopedic injury, and I spot a heart on the chest x-ray, you should call cardiology. Cardiology affirms that is a heart on the chest x-ray, but he has no chronic cardiovascular problems. The medicine consultation could see him. There's all of this back and forth on a time-sensitive disease and injury, right? The sooner these people get to the operating room, the better they do. What if this gentleman had come in with this? Right? This is a clear STEMI. There's no question about it. And I suspect every hospital, every emergency department has a clear process for multiple IVs, monitor, aspirin, clopidogrel, ticagrelor, whatever it is, heparin, calling the cath attending, making sure there's a CCU bed, making sure patient placement is aware. But when it comes to the geriatric syndrome of a hip fracture, there is often a back and forth and not sort of a clear process. And the 1-year mortality for these conditions, for all comers, hip fracture, over 21%, acute myocardial infarction, pretty close. So this is a time-sensitive disease with real morbidity consequences that I don't think we really have streamlined. And I think some of that has to do with the fact that it's a geriatric syndrome. So why do you care, or why should you care? So age-related stereotypes associated with increased depressive symptoms, increased lifelong depression. This gets back to that comment I mentioned earlier. So negative self-perception of aging is associated with increased cognitive decline. Ageism in and of itself is a risk factor for social isolation and loneliness, and so that in and of itself is an entire separate topic, social isolation and loneliness. But just to share this graphic, which I think is particularly telling, this is from a 2010 meta-analysis looking at 148 studies. The top 3 variables are social relationship variables. The bar is decrease in mortality, right? So you want a longer bar. And so social relationships have the greatest decrease in mortality compared to many of these other variables, including smoking. If you smoke, you should stop. And if you know an older adult who smokes, they should stop as well.
But what if they smoke with friends?
Well, it's true. It's a balance, right? So if stopping smoking means they can't hang out with their friends, then I suppose you'd have to do the math. Pneumococcal vaccine, right? You should encourage older adults to be vaccinated against pneumococcus, but when it comes to social relationships, that is even more important from a mortality standpoint. So age-related stereotypes associated with increased loneliness, social isolation. I thought this was a really interesting study from 2021. So this looks at structural ageism in, I think it was 56 countries, and then compared that to actual violence against older adults. And so they described country-level structural ageism in a number of different ways. So social policies, health policies, employment protections for older adults, that was associated with lower structural ageism. And so countries that didn't necessarily have that in place thought to have higher structural ageism. I don't know if it's a huge surprise, but I do think it's interesting. There's an increase in violence against older adults in countries that have higher structural ageism. Increased age is associated with increased non-adherence to atrial fibrillation guidelines, which is associated with increased all-cause mortality. I think a lot of that has to do with stopping anticoagulation, which is a good thought when someone comes in after a fall, but most of the time, they should probably be continued. How about the failure to thrive diagnosis, right? So this diagnosis, which I have made from time to time, associated with delays in identifying sort of the true underlying cause of why a patient might present, I would describe this as somewhat of a cognitively lazy diagnosis and a bit discriminatory. And I would contrast that with the diagnosis in the 1950s and 60s of female hysteria, which right now we would say is ridiculous, right? Discriminatory, lazy, missing, seizures or fluid retention or insomnia, just sort of a catch-all term. I think failure to thrive is the equivalent for older adults. And so I think if we really need to be cautious about making that diagnosis. So we've, I think, identified ageism in emergency medicine, and at least I've described a couple of examples that I think we see on a fairly regular basis, some of the health consequences associated with it. So what are some things we can do, and what are some tools we can consider when it comes to trying to reduce that? So I think discussions like this and acknowledging its existence is particularly important. So increase educational intervention. So this is a meta-analysis looking at 63 studies in the public health literature, looking at trying to reduce ageism by increasing intergenerational contact. And so, I don't know that it's a huge surprise, but educational initiatives that try to do that, to decrease ageism, in fact, does so. So I think more opportunities for learners, particularly in healthcare, to really sort of have that connection with older adults, and often in different settings that they would normally be in. I think that's important as well. Increased awareness and discussion of geriatric syndromes in emergency medicine training improves knowledge and positively impacts practice. So I think that is certainly important to consider. Including older adults in research studies. They are often excluded, and they're often excluded in studies looking at conditions or syndromes that tend to impact older adults. So this first study is looking at a disproportionately low number of older adults in Parkinson's disease research. Certainly that doesn't just impact older adults, but it does disproportionately. The second study is osteoarthritis research, tends to have underrepresented older adults, right? That tends to be a disease of aging. And that the last study published in Academic Emergency Medicine really sort of speaks to the lack of older adults included in research studies in emergency medicine as well. So I think we can certainly do better. And the last, I would say it's important to sort of practice what you preach. I think that the healthcare system as a whole does a very good job of advocating for children. and looking out for the well-being of children. I think that we, as individuals, generally do a good job of looking out for older adults who we are very close with. So particularly our parents, our grandparents, right? When we are the caregiver at the bedside, I think we are good at doing that. But somehow that sort of advocacy that is preserved for pediatric patients and children tends to sort of wane a little bit when we step into the role as a healthcare provider. So these are important older adults to me, two of the most important older adults to me. And so I would ask you to sort of reflect and think of the two most important older adults to you. And as you're thinking about them, just to sort of reflect on the last 15 minutes, is just sort of what I'm hopeful is that we're able to frame the importance of age-centric care, of age-centered care, the consequences associated with our prejudices when it comes to caring for older adults in the emergency department and ageism, and really hopefully provided you with some tools and some things to sort of think about when it comes to making sure that we're providing the most appropriate and most patient-centered care to the older adults we see in the emergency department, and particularly the same care that we would want those special older adults that you're thinking about to receive as well. So that's what I have prepared. I'm happy to hear sort of feedback, comments, questions. Dr. Kennedy.
So comments. Pretty good thought. I think one of the also interesting things is the intersectionality around a lot isn't anyways, but with respect to ageism, there's a lot of intersectionality with disability as well. So a lot of the issues that we see include sort of prejudice perspectives of people with functional disability, with cognitive disability. So I think that's a particular challenge because then you're unpacking both your ageist beliefs as well as some of your negative perceptions of people with dementia, for instance, or frail older adults with physical limitations. So I think it's a challenging area to address because you have to not only unpack the ageist beliefs, but
Yeah.
some of our perceptions
Right.
around disability.
No, I think that's true. And yeah, I think in the point I mentioned at the beginning, and even just those pictures, right? I mean, that shows an older adult, but also with some sort of mobility problem as well. Yeah. Other comments? Dr. Henson.
Yeah, great talk. I know that you pursued geriatric certification for EDs, and we talked about that. What would your advice be to folks who are in like a smaller ED and are not going to pursue that? Are there like standard things that could be implemented across all EDs to kind of mitigate this?
Yeah, so a lot of the people in the audience, I think about this on a fairly regular basis, and so I think one thing that comes up from time to time is good geriatric emergency medicine care is just like good emergency medicine care, right? And so a lot of the things that we sort of focus on for older adults is having physical therapy available, engaging the caregiver. Like, why would you not do that for everybody? And so I think to your point, Jeremiah, of particularly smaller places with limited resources. I think sort of things that can be considered and sort of looked at. So there are geriatric emergency department guidelines. I think one thing that I have found helpful, really honestly, in the last maybe last couple of years, and talking with other people, is there's a lot of other people, often in hospitals or health systems, and even smaller ones, who are thinking about older adults, but sort of doing it in silos. And so I think when you're looking at whether you're going to pursue accreditation through ASAP or age-friendly accreditation, is sort of connecting with others who may be doing similar things, and getting, I think, sort of a better understanding of what that population is and what those older adults lack. And so I think when it comes to particularly smaller sites, is really sort of gathering those resources, understand what others are sort of doing in the community, sort of in the department. So even if you're not going for geriatric emergency department accreditation, I think sort of overlapping many of the similar sort of interests and resources and goals is certainly a way to tackle that, if not going for accreditation. Yeah. Other comments, thoughts, hopes, wishes, desires?
definitely policies in place to take care of those issues, right? Either telemonstros or through transfers. And so, want to consider
Yeah. Yeah, I think that, that's a great point. Not only just partnering sort of within the hospital and who else is doing sort of similar work and thinking about similar stuff where you could sort of combine your resources, but yeah, with just sort of other hospitals and combining sort of efforts or resources, yeah. Rich?
This is a great talk, Bill. So, given like issues of rising EV fortune and the baby boomer population, and I guess like the geriatric group with emergency medicine, I've been thinking about this for a long time. Like, what's your group's sort of role in kind of advocacy for old people lying in stretchers and, always, and the fact that that's probably going to get worse. Like, how are the geriatricians and the EM community thinking about trying to address that?
Yeah. So I have a lot to say, and I think there are other people in the audience who probably have a lot of things that they'd want to say as well. So I don't know that the geriatricians actually are thinking about it as much as the emergency medicine physicians who are more sort of geriatric oriented. So certainly there's been, publications sort of suggesting that, older adults who board in the emergency department do worse. They're more likely to die, right? They increase mortality. There have been efforts within geriatric emergency department accreditation, within ASAP, of really sort of bringing that to the forefront. And so I forget whether it's level 2 and level 1 actually have to report on these metrics. As part of your accreditation, you have to report on the boarding metrics specifically. And those are even sort of optional care processes. What are you doing for your older adults who are boarding in the emergency department? And sort of recognizing that that is a huge issue, not only within all of medicine, but
Just as you're talking, I'm just wondering, like, has there been any thought of making like a poorly Chico measure?
So there is an AGEM is advocating for 40 hours to be,
So there's two things. There's one CMS metric that was proposed with Yale, I believe, that includes 40 as a reportable metric. And then right now, CMS is also reviewing a proposed age-friendly metric as part of the
Yeah, and I mean, I think, you know, we've briefly had conversations sort of locally about, you know, we prioritize patients for the CT scan, or if they're a stroke, or if they're a trauma patient, or going to the operating room, depending on the condition. I think we should prioritize older adults for getting inpatient beds, because those who don't, I mean, there's measurable morbidity and mortality associated with that. And so I think those are even sort of local I mean, there's evidence to suggest that, and so I think that's a local consideration. But to Dr. Kennedy's point, it's sometimes tough to get all of the players, you know, sort of on the same page.
And then, Charlotte, stories. Stories are impactful. And so if there are stories, we have to try to bring those stories forward.
Which is why I think sort of reflecting on, you know, who's important to you, who's the older adult important to you, when you sort of frame it that way, I think people are like, oh yeah, okay, we could probably do a little bit better. Yeah. Great. Thanks, everyone.